Hello everyone, and welcome to my neuroanesthesia rounds. Thank you for previewing my presentation, and I hope you are all able to join me on Tuesday, March 8th at 5 o'clock via Zoom to go over any questions, comments, or concerns you might have about this presentation. Today we'll be talking about brain stimulators and the neuroanesthesiologist. This is a brief outline of what we'll cover in this presentation. First off, we'll go over indications for deep brain stimulator insertion, the pathophysiology of Parkinson's disease, DBS procedure itself, anesthetic considerations, anesthetic technique, contraindications of deep brain stimulator insertion, perioperative complications, and the anesthetic management of patients with DBS presenting for non-neurological surgery. We'll start with a case. A 68-year-old man presents with a history of slowness of activities and asymmetrical tremors for the past 13 years and difficulty in walking with frequent falls. He takes Syndopa, which is a combination of carbidopa and levodopa, but for the last 6 years, he suffered with dance-like movements. The disease has now gradually progressed, and for the last 3 years, his dyskinesias have also increased. He is now scheduled for elective surgical implantation of a deep brain stimulator. In regards to his past medical history, there isn't much to add other than he's an ex-smoker. His only medication is the Syndopa. He has no known drug allergies and has not had any previous surgeries in the past. On physical exam, his vitals are all stable. He is 72 kilos, conscious oriented. There's no pallor, icterus, cyanosis, or clubbing. His MMSE is 30 out of 30, and all cranial nerves are within normal limits. His strength is 5 out of 5 bilaterally, and in regards to his tone, he has more rigidity on his left compared to his right. His deep tenon reflexes are 2+ bilaterally. What is your anesthetic plan for this patient, and is he an appropriate candidate for this procedure? So let's go over the indications for deep brain stimulators. Initially, they were approved only for Parkinson's disease, but has now expanded to include other movement disorders such as essential tremors and dystonia. DBS are also being studied for other uses as well, including Alzheimer's, spasmodic dysphonia, orthostatic tremor, Mige syndrome, cluster headaches, trigeminal neuropathy and neuralgia, chronic pain, Tourette syndrome, epilepsy, restless leg syndrome, obesity and addictions, disorder of consciousness, and certain psychiatric illnesses such as aggressive behavior, depression, and OCD. Next, we'll touch on the pathophysiology of Parkinson's disease. The basal ganglia includes the striatum, globus pallidus, subthalamic nucleus, and the pigmented component of the substantia nigra known as the pars compacta. These brain areas are known to be involved in the control of movements. The clinically important motor circuits originate in the sensory motor cortex and terminate in the supplementary motor area. There are 2 outflow tracts from the basal ganglia. One is the direct pathway via the internal part of the pallidum, and the other is the indirect pathway via the external globus pallidus, subthalamic nucleus, and the internal globus pallidus. The nigrostriatal pathway makes the facilitatory synapses via dopaminergic type 1 or D1 receptors upon direct pathway neurons, and inhibitory synapses via D2 receptors upon indirect pathway neurons. Cholinergic neurons are excitatory and dopamine is inhibitory to projection neurons. In Parkinson's disease, there is a loss of dopaminergic neurons in the substantia nigra of the basal ganglia. This produces an imbalance in the dopamine-acetylcholine ratio and results in the facilitation of the indirect pathway. This is associated with an increased activity of inhibitory nuclei in the basal ganglia, leading to excessive inhibition and a shutdown of the thalamic and brainstem nuclei. Thalamic inhibition leads to the suppression of the cortical motor system, which results in akinesia, rigidity, and tremor, and inhibition of brainstem locomotor areas that may contribute to abnormalities of posture and gait. The classic triad of Parkinson's disease consists of skeletal muscle tremor, rigidity, and akinesia. Skeletal muscle rigidity first appears in the proximal muscles of the neck. The earliest manifestations may be loss of arm swing when walking and absence of head rotation when turning the body. There is facial immobility manifested by infrequent blinking and a paucity of emotional expression. Tremors are characterized as rhythmic, alternating flexion and extension of the thumbs and other digits, also known as the pill rolling tremor. Tremors are more prominent during rest and tend to disappear during voluntary movements. Deep brain stimulators apply intermittent direct electrical current to the selected target with frequencies above the native firing rates in these areas. It was initially proposed that stimulation blocked depolarization of neurons within close proximity to the electrode. However, effects on neurotransmitters from the neurons not in close proximity suggested other mechanisms of action, such as effects on neurotransmitter release. The overall net clinical effect of DBS appears to be largely an inhibitory effect, though not equivalent to a standard ablation-type lesion. Entrainment of local neurons has been demonstrated during intraoperative stimulation of neurons in globus pallidus interna, and alterations in neuron firing have also been demonstrated during intraoperative stimulation of subthalamic nucleus. When it comes to anesthesia, there are many disease-specific concerns in patients with Parkinson's disease. Neuropsychiatric symptoms of Parkinson's disease include cognitive dysfunction, dementia, behavior and mood changes, delusions, and hallucinations. These symptoms affect some Parkinson's disease patients' ability to provide an adequate past medical history and cooperate during the procedure, and may also affect their emergence after anesthesia. Respiratory complications are the leading cause of death in patients with Parkinson's disease. These include both restrictive and obstructive pulmonary disease. An obstructive ventilatory pattern is observed in 1/3 of patients with Parkinson's disease and appears as a sawtooth appearance on flow volume loops. The chest wall rigidity contributes to the restrictive pattern and predisposes these patients to a high risk of developing pneumonitis. Upper airway dysfunction might occur due to uncoordinated involuntary movements of the pharyngeal glottic and supraglottic structures that results in the retention of secretions, intermittent upper airway obstruction, and aspiration. These patients are also at risk of post-extubation laryngospasm and respiratory failure. Sleep apnea has also been described in post-encephalitic Parkinson's disease. Dysphagia results in poor nutrition and low albumin levels, which can alter the pharmacokinetics and pharmacodynamics of anesthetic agents. Cardiovascular manifestations in patients with Parkinson's disease include cardiac arrhythmias, dependent edema, and orthostatic hypotension. Direct-acting dopamine agonists, such as bromocriptine and glyceride, and antidepressants, such as amitriptyline, also aggravate the orthostatic hypotension. Gastrointestinal manifestations, such as sialorrhea, dysphagia, abnormalities of esophageal function, and constipation. These patients are predisposed to gastric stasis and gastrointestinal reflux and increases the risk of aspiration pneumonitis. Parkinson's disease and its drug treatments might lead to autonomic nervous system dysfunction. The goals of drug therapy in Parkinson's disease are directed to increase the availability of dopamine or the receptor's response to dopamine and decrease cholinergic activity. Systemic administration of dopamine is not effective in the treatment of Parkinson's disease as it does not cross the blood-brain barrier. A precursor of dopamine, levodopa, has revolutionized the treatment of Parkinson's disease. It is routinely administered along with a peripheral decarboxylase inhibitor to prevent its peripheral conversion to dopamine. In this way, the side effects such as nausea, vomiting, which are due to the activation of dopamine receptors in the area postrema, can be prevented. The levodopa therapy is associated with acute dopaminergic side effects such as nausea, vomiting, and orthostatic hypotension. There are fluctuations in motor response and involuntary movements, known as dyskinesias. The relatively short half-life of approximately 60 to 90 minutes is responsible for the off phenomenon. The goals of anesthetic management for DBS insertion are to provide adequate operating conditions, patient comfort, to facilitate intraoperative monitoring, including neuromonitoring for target localization, and to diagnose and treat any complications occurring during surgery. The placement of DBS electrodes involves 2 stages. The first stage is the insertion of the electrodes into the target area of the brain, and the second stage is the internalization of the leads and implantation of the programmable pulse generator. Typically, in most centers, the first stage is usually done under conscious sedation and the second stage under general anesthetic. Usually, both stages are separated by a few days to weeks. However, there is a recent trend in performing both stages in the same setting. Currently, there is limited evidence favoring the best timing of the second stage, and often the choice will be determined by many factors, including the duration of the procedure, patient cooperation, and the type of anesthesia, for example, GA versus conscious sedation. Several methods are commonly used to improve the accuracy of target localization. These include stereotactic frame-based imaging, intraoperative microelectrode recordings, and macrostimulation testing of an awake patient. A stereotactic head frame is usually placed under local anesthesia while the patient is awake. Scalp blocks have been shown to be superior to local anesthesia in providing analgesia, as well as better intraoperative hemodynamics and less need for antihypertensive medications during surgery. However, patients who are uncooperative or unable to tolerate this procedure may require IV sedation or GA. Once the stereotactic frame is in place, MRI or CT is performed to identify target nuclei, allowing the surgeon to calculate the coordinates for electrode insertion. When using the stereotactic head frame, the head and neck should be positioned in such a way that the airway is patent, and it is possible to secure the airway in an emergency. In patients with obstructive sleep apnea, continuous positive airway pressure might be required intraoperatively. The face mask should be fitted prior to the head frame application. During a DBS insertion procedure, many centers use electrophysiological guidance with microelectrode recording and macrostimulation to localize and confirm the target nuclei. Microelectrode recording are spontaneous and stimulus-evoked neuronal discharges recorded via a microelectrode as it is advanced towards the target nuclei. There are variations in the spontaneous firing rates and patterns amongst different target nuclei that enables specific target localization. In macrostimulation testing, the implanted DBS electrodes are used to stimulate the target nucleus briefly in an awake patient to confirm the improvement in symptoms such as tremor and rigidity without causing side effects. Recently, many centers are using intraoperative MRI for target localization and confirmation of electrode placement without the use of a stereotactic head frame, microelectrode recording, or macrostimulation. This is advantageous for patients who cannot tolerate or refuse an awake procedure. In addition, MRI-guided DBS insertion has shown to be anatomically more accurate with similar clinical outcomes, costs, complications, as well as operative times compared to the traditional awake technique. Anesthetic agents, both IV and inhalational, influence the microelectrode recording and are a major concern during intraoperative target localization. GABAergic anesthetic agents have been shown to affect both background activity and neuronal spike activity. These effects may not be homogeneous in all regions of the brain. Non-GABAergic drugs, such as dexmedetomidine and ketamine, and short-acting opioids, such as fentanyl and remifentanil, have minimal effect on microelectrode recording. Propofol, although it attenuates microelectrode recording, has been used successfully. Benzodiazepines are direct GABA agonists that can abolish the microelectrode recording and macrostimulation testing, and also cause respiratory depression and impairment in consciousness, therefore should be avoided. Dexmedetomidine has become the preferred sedative due to its non-GABA mediated effect. It provides sedation and anxiolysis with minimal respiratory depression. Based on the limited current literature, most evidence indicates that low-dose dexmedetomidine at a rate of less than 0.6 micrograms per kilogram per hour, with a bispectral index of greater than 80, is a safe anesthetic agent to use during DBS surgery. However, the consensus remained that the use of anesthetic agents should be minimized during microelectrode recording whenever possible. This slide here is a summary of the anesthetic considerations for DBS insertion, many of which we have already touched upon. They can be broken down into preoperative, intraoperative, and postoperative considerations. Preoperative considerations include it is common practice to withhold or modify the morning dose of disease-modifying medications to facilitate intraoperative testing. The patient may be difficult to communicate with and have difficult IV access, monitoring, and positioning issues. This is due to movement disorders, dystonia, developmental delay, dementia, or behavioral problems. Intraoperative considerations include potentially difficult airway, pulmonary changes placing the patient at high risk for aspiration, as well as hemodynamic and autonomic instability. Postoperatively, you can have delayed emergence due to reduced neuronal activity in the basal ganglia and potentiation by GABAergic drugs. Choice of anesthesia agents and techniques vary based on individual institutional practice. In addition, it also depends on the patient population and the indication for DBS insertion. Monitored anesthesia care with local anesthesia and sedation is the most widely used anesthetic technique as it facilitates the intraoperative neurophysiological monitoring. However, GA is often used for patients who cannot tolerate an awake procedure, such as pediatric patients, patients with extreme anxiety, developmental delay, severe off-medication symptoms, or patients with behavioral disorders. In addition, some centers routinely perform all DBS insertions under GA, with or without microelectrode recording under intraoperative MR guidance. A recent meta-analysis published in the Stereotactic and Functional Neurosurgery Journal in 2019 showed that there were no significant differences in clinical outcomes or postoperative complications between asleep and awake DBS implantation. Over 1,500 patients were included in this study. Furthermore, the subgroup analysis showed that microelectrode recording might not affect target positioning and postoperative clinical outcomes. This shows that for patients who cannot tolerate surgery awake, GA is still an appropriate alternative. In regards to the intraoperative management of patients undergoing DBS insertion, for optimum patient comfort and cooperation, careful positioning, adequate pain control, avoidance of excessive fluid administration, and temperature control are essential intraoperatively. Standard anesthesia monitors, including ECG, non-invasive arterial blood pressure, oxygen saturation, respiratory rate, and end-tidal CO2 should be routinely used. Non-invasive blood pressure readings may not be feasible during the awake portion because the patient's tremor returns. An arterial line would be indicated in that circumstance as well. Invasive blood pressure monitoring might also be required for patients with labile blood pressures. Options for securing the airway at any stage of the procedure should be considered if awake anesthesia is planned, such as having an oral airway LMA ready, fiber optic bronchoscopy, video laryngoscopes, and bougie in the room, including the head frame wrench for it should be removed in case of emergency. The room temperature should be controlled as these patients are usually elderly and might have associated autonomic neuropathy, and both these conditions impair temperature regulation. Anticonvulsants must be readily available. A urinary catheter is not routinely used as it would be uncomfortable to place in an awake patient. The patient's motor systems and level of consciousness should be closely monitored by the anesthesiologist. BIS can also be used to titrate hypnotics and predict awakening. Previous studies have shown that the incidence of perioperative anesthetic complications during DBS surgery is between 12 to 16%. The common complications and recommended treatments are listed in the table above. Intraoperative hemodynamic fluctuations during DBS surgery are one of the most common complications. Control of blood pressure is important to minimize the risk of intracerebral hemorrhage during electrode insertion, especially in patients undergoing DBS insertions under monitored anesthetic care and sedation. Short-acting hypertensive agents such as the betalol, hydralazine, nitroglycerin, sodium nitroprusside, or esmolol should be used to control hypertensive responses. Beta blockers are best avoided as they may interfere with the testing of tremors. Contraindications of DBS implantation include factors that increase either the operative risk or the risk of device malfunction in patients in whom the effectiveness of DBS is limited. Patients carrying an increased operative risk include coagulopathy or uncontrolled hypertension. Device malfunction can be caused by MRI using a full-body radiofrequency coil, shortwave, microwave, or therapeutic ultrasound diathermy near the implanted device. Patients with expected limited benefits include those with psychiatric illnesses, dementia, and cognitive deficits in patients with unsuccessful test stimulation. These patients are associated with a higher incidence of depression and cognitive deficits after DBS insertion. Patients with early Parkinson's disease, which is considered a duration of less than 5 years, and extremes of age, greater than 70 years, are considered relatively contraindications for DBS insertion. DBS is not indicated for dopamine unresponsive syndromes such as walking, talking, and thinking problems. Okay, so back to our case. The DBS has been successfully placed in a two-step procedure, first under conscious sedation and second under general anesthesia. There were no issues or concerns perioperatively with either procedure. The patient is very happy with the outcome, for his symptoms are now well controlled. He presents approximately 12 months later in pre-admission clinic for a scheduled laparoscopic cholecystectomy. How would you proceed with this patient, and what are your considerations? With increasing number of patients undergoing DBS surgery worldwide, patients with DBS in situ presenting for non-DBS related surgeries have increased. The major considerations in the perioperative treatment of patients with an implanted DBS system include what is the medical condition that warranted DBS insertion, potential for electromagnetic interference with the DBS system, for example, electrocautery use and MRI, and postoperative evaluation of the patient and device. From the review article published in the Canadian Journal of Anesthesia in 2017, the preoperative management of these patients coming for surgery include assessing the patient ideally in a pre-admission clinic setting for indications for DBS insertion, optimizing medical issues such as ischemic heart disease and diabetes, and current medications. You want to obtain the following information related to the DBS device from the patient, the DBS device information card, or the DBS physician. You want to know the DBS model, IPG location, last check, and battery change by the DBS physician, the current settings, programmability, and prior device complications, the severity of symptoms when the device is turned off, and you want to learn the use of the patient programmer, especially how to turn the device on and off. You want to consult the patient's neurologist or DBS physician to discuss specific precautions and postoperative assessment of both the patient and the device. You want to get a chest x-ray to identify the path of DBS device wires to avoid damage during surgeries close to the device and to identify the type and make of the device. And you want to arrange with the device representative or DBS physician for interrogation and adjustment of DBS settings prior to going to the OR. Intraoperative management includes turning the DBS device off to minimize electromagnetic interference. Older models should be powered down or the amplitude switched to 0 volts before turning off the device. You want to turn the DBS device off after induction of general anesthesia if recurrence of symptoms is severe. During regional anesthesia, you want to increase sedation if symptoms are severe. And for emergency surgery and when programmer is not available, you want to proceed with caution for electrocautery. You want to turn the DBS device on before the reversal of anesthesia and emergence. Precautions with electrocautery include the use of bipolar cautery mode with minimum power settings. You want to use it in short, intermittent, irregular bursts. If unipolar cautery is utilized, you want to place the grounding pad such that the current path between the active electrode of the electrosurgical unit and the pad does not cross through the DBS system. In regards to postoperative management, a neurological exam is needed to rule out any adverse events related to device interaction, and the DBS device should be checked by the relevant device representative or DBS physician postoperatively. The use of MRI in patients with an implanted DBS device was previously an absolute contraindication due to electromagnetic interactions that could potentially result in patient morbidity. The safety concerns with MRI include excessive heating at the electrode tips of the DBS device due to compounding of the current produced by the gradient and RF magnetic fields within the DBS system, magnetic field interactions, image artifacts and distortion, and functional disruption of the DBS system. The amount of heat generated within the DBS system is dependent on several factors, including electrical properties of the neurostimulator, field strength of the MRI system, position of the DBS components relative to the RF energy source, type of RF coil used, point of imaging, and the specific absorption rate. Some neurostimulators are now MRI compatible, but even once MRI eligibility has been established, the scan must be performed under specific conditions. DBS should be turned off during imaging, which in some patients can lead to recurring symptoms that interfere with adequate image acquisition. After imaging, the DBS specialist should check the neurostimulator and turn on the device to its original settings. The safety concerns of performing ECT in patients with implanted neurostimulators include generation of heat at the DBS electrodes from induction of RF current by the electrical charge, functional disruption of the DBS system, and displacement of electrodes from induced seizure activity. 3 case reports showing safe administration of ECT recommend the following precautionary measures: turning the neurostimulator off, placement of the ECT electrodes as far away as possible from the DBS electrodes, and the use of the lowest possible energy for seizure induction. In summary, DBS is an effective treatment for an increasing variety of neurological and psychiatric disorders. Therapeutic indications have a significant impact on perioperative anesthesia management. Monitored anesthesia care with local and IV sedation is most widely used, with dexmedetomidine being the preferred sedative. New technologies like frameless stereotaxy and intraoperative MRI have altered the need for intraoperative neuropsychological monitoring and increased the use of general anesthesia for these procedures. Potential intraoperative complications can occur perioperatively, including airway emergencies, intracranial hemorrhage, venous air embolisms, and seizure. With an expanded number of patients undergoing DBS implantation, patients with pre-existing DBS increasingly require anesthesia for unrelated surgery, and the anesthesiologist must be aware of the considerations for perioperative management of these devices. Thank you all for viewing my presentation. Again, I'm looking forward to seeing you all over Zoom on March 8th to discuss this topic further. The rest of the presentation is just a couple of slides with questions in regards to the content that we have covered throughout this presentation. If you have any questions or concerns, please feel free to reach out and contact me at your earliest convenience. Thank you.